14th Annual Global Cardiomersion Conference on Cardiovascular Care at
Previously,
Mohali.
he had undergone an angioplasty for an atrial myocardial infarction. Ejection fraction was 20%. Top I was significantly elevated. Anti-pro-BNP was more than 18,000. This is what we found on the angiography. Territory, non-viable myocardium. Now another acute myocardial infarction, 65-year-old male, ejection fraction 20% on IABP, triple inotropes, decreasing urine output, need for progressively increasing doses of inotropes. We decided to do a protected angioplasty. This is what we found. Right coronary was a non-dominant vessel. The only vessel was left main, and left main had critical distal bifurcation lesion, and there was a critical lesion of proximal LAD and proximal circumflex. Circumflex was a dominant artery. So this patient with ejection fraction of 20% obviously could not have undergone a bifurcation stenting without an impella. So we deployed an impella on this particular patient and then did a bifurcation angioplasty stenting. You can see the IBP was removed and then the BK crush technique was used to do a left main bifurcation angioplasty stenting. The right coronary in the same sitting in a patient who was in cardiac shock and undergone a left main angioplasty. So this is balloon angioplasty. Then we did a roto-ablator of the right coronary artery, and after that we deployed 3 long stents in the right coronary artery. Did an OCT to say that we have optimized the result.
CTFFR again, it's a common tool which has been reportedly telling us more and more about functional assessment over an accurate assessment by CTVS. But again, it's not very commonly available in India, and CT perfusion studies can be done, but they are not the gold standard. And of course, cardiac MRI has been taking increasing role in management of CAD patients. Unfortunately, again, the expertise is limited. We have MRI machines available widespread, but cardiac MRI is something which needs input by the radiologist more over and above what they are generally reporting. But if used nicely, it is the gold standard right now for assessment of biventricular function. For ischemia assessment, again, it's very useful test. Viability assessment by LG can be done. And of course, perfusion studies, if available, can tell us about microvascular dysfunction also.
We recently dealt a case, the 54-year-old gentleman with a medical background of type 2 diabetes mellitus presented with a history of angina pectoris for last 1 hour, and his ECG showed interoceptal STEMI, and on echocardiogram it was a global hypokinesia more in the LAD territory with EF of around 35%, and immediately loaded with aspirin, torvastatin and prasugrel as per the guidelines. Here you can see in ER room the upsloping ST elevation V1 to V4 and with the reciprocal changes in the inferior leads. So immediately we shifted the patient to the cath lab. Good TIMI3 flow. Next. Yes. And this post PCI run, OCT run. This week. The post PCI run, you can see there is a good expansion. More than 90% expansion is optimal. Less than or more than 80% is acceptable. More than 90% is optimal. We have around 100 to 150. So it means there was a good apposition as well as
you have to optimize the preload all the time in the immediate post-op period, and side by side you have to see that the contractility is maintained while reducing the coronary resistance. For that you have plethora of drugs available in the form of ironodilators, starting from zobutamine to vildarinone. You can use epinephrine. Some studies have evaluated and tried levosimendan, though we have not used, not recommended, not clinically very useful as far as end results are concerned. At the same time, you can use selective pulmonary vasodilators like inhaled nitric oxide prostaglandins and phosphodiesterase 5 inhibitors to control the pulmonary hypertension. Now coming to renal function and fluid management, this is one of the very important aspects in the immediate perioperative period, post-operative period. Because why we are worried is we have to balance out the kidney function with newly implemented nephrotoxin, immunosuppressant drugs, as well as the cardiac output in newly implanted allograft heart. How does it function? If it is functioning appropriately, the cardiac output normal, then the kidney GFR will be maintained. Otherwise, in the pre-operatively, we know that these are chronically heart failure patients. Already their kidney perfusion was suboptimal, and immediately they can face problem with kidney impairment. For this reason, you have to be very careful from the beginning. You have to maintain the preload very diligently. The filling pressure has to be maintained slightly. Now coming to the rejection. Rejections can be cellular rejection or antibody mediated rejection. So acute cellular rejection will manifest, all these rejections will manifest as features of heart failure. Patient will be fluid overloaded. If the patient already extubated in the early post-operative, they may present as breathlessness, they may have desaturation, they may have hypotension, they may consistently, gradually require higher and higher inotropic support, and they will retain fluid, urine output will decrease, capillary perfusion will decrease. So, how you diagnose? You do a
I think some of you might have visited Government Medical College, Chandigarh. This is one of the top ranking medical colleges. At NRF we rank at 35. In India today ranking we are at among the medical colleges on top 10. But if you include AIIMS and other big institutes like AIIMS like institute, we are at 15 right now this year. So this is a very nicely designed hospital. It initially, if you enter, some of the parts they give a feeling of a corporate sector, but then we have a major problem of footfall, so that's why the facilities are constrained. So you require a bigger OR space for cardiac surgery. You have to literally take off the fund. So in this case, the UT administration decided to take over the fund from the allocated fund to the Government Medical College out of the allotted fund by the Union Government to the Union Territory of Chandigarh. Most of the theatres are not modular because they were started in 2002-3. So that time modular concept had not come. So we were not having that. So we used the old operation theatre, the bigger one among all the 7 operation theatres of surgery, and then we did certain modifications to start the cardiac surgery.
Double lumen tube was being put earlier, but nowadays we use the anesthetists use blockers. Left femoral line, right femoral cannulation, and this is just a small. Yet the long lines which you are seeing is of the stenotomy, and the small line which you see is the scar on the left side is the marking which we put for an incision. Each and every operation theatre should have a TE or a transechocardiac machine, which is a must if you are proceeding for MICS in all patients. And this is the retractor which we keep for harvesting the left internal mammary artery. This is usually set up once the patient is on the table, and these are the set of instruments which we use. So the most important benefit is no bone is cut and there is less amount of pain, early recovery, and there is less infection, and since the handling is less or the tissues, number of tissues which are being cut is less, so the blood loss is also less, and the most important factor is It's a boon for unmarried girls. Nowadays, it does not matter with unmarried girls. Even an old man of 75 or 80.
The white line, the incidence of the complications has been more or less the same, roughly about 1 to 2% of the myocardial infarction. If you see the mortality bars, in the pre-perfect era, the mortality was high, almost to the tune of 70 to 80% of these important mechanical complications. It has definitely come down with the evolution of therapies. However, there has not been a very drastic change even with the more modern treatments. So that is definitely a cause of, let's say, introspection and maybe further efforts to improving the mortality figures related to these complications. So coming to the pathophysiology and management of post-MI VSR, we all know the important coronary arteries of the heart, the LAD and the left system and the right system. You have the LAD and the LCs, and you have a right coronary artery which divides into the PD and the PLV. So depending on the area of the infarction, you can have means the ventricular septal rupture. If you have the LAD or the anterior arteries of the heart involved in MI, you will expect a apical or anterior septal VSR. If you have the artery involved, you will expect an inferior VSR. So what essentially happens is that most of the patients wherein you see the VSR usually have critical single vessel disease. They don't have chronic long-standing triple vessel disease because that will lead to formation of good collaterals and you won't expect a VSR. So poor collateral formation and a sudden complete obstruction that predisposes to the formation of the VSR. So you can have simple or complex VSRs, wherein if you if you have an anterior VSR, usually there is a direct communication between the LV and the RD, and the track is not serpiginous, it is straight. So surgically also management becomes a bit easier. If you have a more complex VSR, as in the anterior VSRs, which happens because of the involvement of the right coronary artery and its branches, you can see that the track of the VSD is serpiginous. So you may miss closing the VSD completely during surgery. So that is important to understand the pathophysiology of these two types because it has a bearing on the management, surgical management. So these are some of the diagnostic features, and pathophysiology, you obviously will get a massive left to right shunting because of the VSD depending on the size of the
Exposure to LDL for a longer duration is a havoc for the body. If it starts from the childhood, people get premature cardiovascular disease and die, then they die. Another issue is if we lower the cholesterol, it is good for the body, as been proven by numerous trials starting with 4S in 94, going up to many more to follow for primary as well as secondary protection in cardiovascular disease. These are the trials which built up the focus on LDL as a risk factor. Now, here is what we are looking forward to. We were very happy with the cholesterol level of 100 a few years ago. LDL level of 100 used to be ideal. Then it came down to 70, especially in people who are having a severe form of cardiovascular ailment, manifest as atheromatous cardiovascular disease, those who are diabetics with risk factors, and those who have CKD. But this was still not enough. The target was 50 of 55 was again set up for very severe risk factors as well as diabetes as well as manifest cardiovascular disease. But lo and behold, it did not stop there. Now the target is below 40 and some people even say that 15 milligram for extreme risk cases is the desirable level.
Only 9% patients have normal renal functions. And if you look at the worsening renal function in this, 20 to 30% increase in creatinine, more than 0.3 milligram per deciliter. So what are the risk factors? Diabetes, uncontrolled hypertension, and mission creatinine greater than 1.5 was thought to be risk factors for the cardiorenal syndrome. So when we look at cardiorenal syndrome, it's very important to differentiate it from chronic kidney disease. And the reason for doing that is the main thing that we do in cardiorenal syndrome is decongestive therapy or diuresis. And if patient has underlying kidney disease, it may inhibit you from not using diuretics to your optimal level. So it's important to differentiate, and sometimes the differentiation is very easy. You look at the labs from the previous time and you know patient has chronic kidney disease. If they have proteinuria, or hematuria or nephrotic syndrome, you know that there's underlying intrinsic kidney disease. But sometimes it's tricky, and renal ultrasound may help you if you see small contracted echogenic kidneys. You know this patient has chronic kidney disease. Pathophysiology is pretty complex. First, it was thought to be
really complex cardiac surgeries. That was for sending for DTGA and DTGA with an ASO for DTGA with ASD closures. And then in 1990s, in All India Institute, we started with the program of neonatal cardiac surgery. So, especially in neonatal cardiac surgery, the first neonatal cardiac surgery, arterial switch operation was performed by Dr. K.S. Iyer, and in 1993, we started with the Achintya era of neonatal cardiac surgery. So this is a slide that states the differences. At the upper slide, we can see the first blue TAVI operation taking place in November 1944, in which we can see that Dr. Dr. Alfred Blalock and Dr. Thomas are performing the first Blalock-Taussig shunt at that time, which was left-sided shunt from the left to the left pulmonary artery. Then there was a circuit for the extracopular circuit for clinical cross circulation, and then in the last we can see the pump that was by John Kidney. The lower slide we can see the advancements that we have come on to. The advancements in the X4 Berlin heart, that is used as an LVAD device for usually children. Then we have the ECMO that is being currently widely being used everywhere in rapid cardiac surgery as well.
Cath lab, there was a left main dissection. And here you can see the patient had a ejection fraction of 15%, and on the cath lab the patient crashed, intra-aortic balloon pump was put, patient started having ventricular fibrillation and recurrent VT. They gave shock but did not recover, and then the patient was referred to us. So we reached immediately and CPR was started. TPI was put because patient went into complete heart block, and then patient was immediately shifted to the OT, and that time the relatives were not ready. They were confused to give consent. So immediately we had to counsel them and shift the patient. While the patient was on constant CPR, we opened the chest, started open cardiac massage. Immediately we put the temporary atrial and ventricular pacing leads, started pacing the patient. The patient was going into pulmonary edema. So there was frank, frothy blood coming from his endotracheal tubes, and the anesthetist was totally busy, sucking all the time, and it was very difficult to maintain the saturation. And then the Euro score of the patient was 70.7, and patient was on very high inotropes. So we thought that whether we should put the patient on pump, but somehow with the inotropes, the patient was maintaining mean arterial pressure after the intra-aortic balloon pump was put. So we continued with the off-pump surgery, and once the patient was revascularized, then the rhythm came back and the patient started improving, inotropes started decreasing, and in the night there was constant improvement in the hemodynamic status of the patient. By next morning, patient was absolutely stable with very low inotropic support, and after 4 days patient was discharged and is still coming in the follow-up. Ejection fraction has improved from 15% to